as time allows. Now I'm excited to introduce today's ataxia expert, Dr. Susan Perlman. Dr. Perlman is currently a clinical professor of neurology and director of the Ataxia Center at the UCLA Medical Center in Los Angeles, California. Welcome, Dr. Perlman.
Thank you so much for inviting me to this session. And, I hope we can get through basically everybody's questions. The ones that I see flashing up here are, very good questions focused on stuff that's new in the research news, focused on things that people themselves are experiencing. Many are questions that I receive from individuals during regular clinic visits. So, I think it's important to know that no expert can know everything. I came prepared, having tried to read the COVID literature, figuring somebody is going to ask about COVID, but I don't think any of us know everything that is ultimately going to be known about that. So it's, I think that's the, even harder to deal with than CRISPR or gene therapy. But Lori, I'll let you start, working with the questions.
Sounds good. Well, that's a great segue to our first question here in the chat. Are there any treatments on the horizon?
The pipeline for spinocerebellar ataxia, for Friedreich's ataxia, and the growing pipeline for multiple system ataxia or multiple system atrophy have many promising agents. I think in the last year or two, more and more trials are opening up. For the spinocerebellar ataxias, a lot of the trials that are going to be beginning are looking at spinocerebellar ataxia type 3 or Machado-Joseph's disease. And there we have the Biogen study of a gene blocker. We have the CELOS study of an agent to help get rid of the abnormal protein that's building up. We have a stem cell study from the Steminent company, which, hopefully will be starting this coming year. And there are other therapies that are not quite ready to begin human trials. For the non-genetic ataxias, the focus has been on anti-neural inflammation with the Biohaven study of the myeloperoxidase inhibitor verdiperstat. But there are other anti-neural inflammation agents that are in development, which could be applied to any ataxia, genetic or non-genetic, since inflammation around the stressed nerve cells seems to accompany pretty much every form of degenerative ataxia. Friedreich's ataxia has a very active pipeline, and they may have the first drug that's going to cross the finish line for approval with the FDA. That's omaveloxolone, which targets the mitochondrion to improve energy production, which potentially could be used in many other ataxias where there is an energy crisis that accompanies the other things that the gene may be doing. And of course, Biohaven has their troriluzole drug, new formulation of an older drug, riluzole, which should be wrapping up and hopefully will be able to be submitted to the FDA in the coming year as well. That is a less specific drug, although it has been tested in the common genetic ataxias. It again may have application to a variety of cerebellar disorders, since its action is in the cerebellum to stimulate those nerves to work better. So there's a lot happening. Certainly at my facility, we try to be part of every trial. And I know all the other facilities that are part of the NAF Clinical Trials Network are going to be participating as well. So we hope that all these trials will be easily accessible to our ataxia population.
Thank you, Dr. Perlman. You guys certainly are doing a lot of great work over there at UCLA. We have a question specific to trillios. The question is, can you explain how trillios works versus ASO treatment?
Trillios is a form of sugar. If you took it orally, it would be digested in your stomach and probably would turn into, generic sugar particles in your circulation. So that this particular study is giving it by intravenous injection, where the complete molecule can then cross into the brain. And what it does, at least based on their preclinical work and their early clinical work, is it seems to get in and declump the abnormal protein that has been building up in spinocerebellar ataxia type 3. So some of their early work suggested that its administration could slow progression, and we're hoping that there's going to be a larger study that will be able to build on that information, and show slowing of progression, potentially improvement of clinical symptoms. So basically, the disease modifying agents that are in the pipeline, gene blockers, anything that could block or get rid of the toxic effects of a gene mutation, the drugs that could be targeting abnormal protein buildup, free radical buildup, and there are a number of drugs now that are going to be able to target these pathways to slow progression and ideally help some of the partially damaged nerves to heal, allowing improvement as well.
Great. Here's a
And
question
I know that NAF is going to be working on updating a pipeline of drug development similar to the one that's on the Friedreich's Ataxia Research Alliance website for Friedreich's. And I'm hoping that NAF will have an updated pipeline that they can make available to people visiting their website.
Yes, absolutely. We have a question from Rita. Last session, the doctor seemed to indicate that balance can be regained with rehab. Is that the case, and what type of rehab is effective?
Rehab includes all of the non-drug interventions. Physical therapy, occupational therapy, speech therapy are the three primary ones that we look at. And let's look at physical therapy. What you can do with a regular exercise program, and we'll talk about the components of that in a moment, is you can protect your muscles from disuse or not using them, deconditioning. You can retrain pathways to work better together. Since part of ataxia is pathways not coordinating their activities. And it has been shown that some forms of exercise, specifically cardio type exercise, can increase nerve growth factors in the brain of experimental animals. And it's anticipated that these exercise routines can also increase nerve growth factors, which are neuroprotective in the human brain itself. So a good exercise program is going to be personalized to each individual, but typically it will include core strengthening, which can help balance, focus strengthening on other areas, legs, arms, shoulders, hips that may be weak in an individual person. Some rhythmic repetitive exercise, which overlaps with cardio to get the muscles working together in a rhythm. And finally, besides the the cardio that we talked about, the core strengthening that we talked about, balance exercises and stretching. You can, like a gymnast or a ballet dancer, practice balance exercises and improve your ability to control those pathways. And certainly if you have issues with pain or muscle spasms, stretching can be very helpful as well. So these four components, a physical therapist or a trainer can help you put together a program that will be specific for your needs.
That's great advice, Dr. Perlman. We have a question here. Are there treatments for double vision caused by ataxia?
The double vision caused by ataxia can be experienced from several different changes in eye movements. Number one, you could have dysconjugate gaze because of changes in the brainstem, where the eye movement nerves begin all the way out to the eye muscles themselves, where your eyes are just malaligned and one eye turns out or one eye turns in, and you have constant double vision. This is usually treated by an ophthalmologist. They can do surgery to realign the muscle. And, for individuals, for instance, with spinocerebellar ataxia type 3, where they may develop a fixed malalignment, and they've maxed out their prism glasses, realigning with a small surgical procedure can take away the double vision, at least for a few years. Now, some people only experience double vision when they're looking to one side or looking to the other side, or they might have, a skew vision where one is kind of on top of the other when they try to look up or down. That is harder to correct with surgery and harder to correct with prism glasses because it's only in one direction. So I think those are the individuals that have the greatest difficulty managing double vision, because every time they look to one side, they're seeing double. So it affects driving when they're trying to look out the window to see approaching traffic, etc. Nystagmus, which is an eye tremor. When you look in one direction, the eye shakes. You look in the other direction, the eye shakes. Sometimes looking straight ahead, your eye may have movements that make it hard to fixate, and you may get a sensation of seeing double. There are medications that are used for nystagmus that can help reduce that, and hence take away the perceived double vision as well. So I think the hardest group to manage, with prism glasses or surgery or some of the medications, are the ones whose double vision is only when they're looking in one direction or another. Some of the medications may help that, and this is something you need to discuss with your doctor or with your eye doctor.
All right. We have another question here. What drugs are being developed for cerebellum recovery? What can we expect in the next 2 to 5 years? And is there anything that the ataxia community can do to help speed up the process?
I think the treatments in the pipeline now that might lead not just to stopping progression or improving symptoms, but actual recovery of pathways, are things that focus on nerve growth factors. So, there are various, small groups around the world that are working with administration of nerve growth factors. There's a group here in Southern California that is working with a gene treatment of a gene that will make a nerve growth factor and could help restore nerve connectivity in multiple system atrophy. This is going on at University of California, Irvine. The stem cell treatments that are in development, the group in Taiwan, Steminent, that is developing a stem cell treatment for SCA3 and potentially SCA2, is, potentially the activity of those stem cells will be to increase nerve growth factors. And the people at Mayo Clinic also have a stem cell program that is going to be focusing on multiple system atrophy, non-genetic ataxia, again, with probably the connecting link being through nerve growth factors. So I think looking at ways not just to stop disease progression, but to restore damaged nerve pathways, a lot of them are going to relate to nerve growth factors or stem cells. Actual nerve transplants have been tried, fetal cell transplants, et cetera, in Parkinson's disease. But certainly the cerebellum is complex enough in the layers of nerve cells interacting with each other that I think it's going to be very hard to do, a fetal cell transplant or a stem cell transplant and be able to restore the normal architecture. I think we need to work with nerve growth factors and the signals that are still communicating within the cerebellum so that if we can stop the toxic progression of a genetic factor or another factor, it's possible that there will be some natural healing as well. Think what happens after somebody has a stroke. There's going to be a deficit. There's going to be a group of nerve cells that are gone, but there will be nerve cells surrounding the damaged area that can send out new connections, and with rehab, be able to restore function in those pathways. Plus, in our brain, we do have stem cells that have been sitting there since we were born that have never developed into any of the neural pathways that, with the right conditions and nerve growth factors, they could actually grow back in their normal pathways. So neural restoration is a very hot area of research. Unlikely that we will have approved treatments that will do that in the next 5 years. I think that's going to be a longer timeline, but certainly there will be clinical trials going on that, they'll be looking at outcome measures that could show this type of neural restoration. And what was the last question they had in that trifecta of questions there?
Sure. Is there anything that the ataxia community can do to help speed up the process?
I wonder if there's anything that ataxia researchers can do to speed up the process. I sometimes find it a little frustrating that, I've been talking with one particular company for 5 years about their stem cell project, and it still hasn't moved forward to the point where we can begin treating patients. Another group, had been trying for 3 years to raise enough money to do a multi-center stem cell program. And they finally got money, but only enough to do it at one site. So, I think, the wheels of drug development turn, frustratingly slowly, because of regulation, because of funding issues, because, something gets bumped for, a project that looks, more interesting or more promising than a rare disease. So, I think the one thing we can do as a community is certainly participate in any research that comes within our grasp. Most of the drug companies are interested in large groups of motivated individuals who are willing to participate, groups of individuals that already have a baseline that has been well defined, natural history studies, biomarker studies, which are being, sponsored by the National Ataxia Foundation. Even, the ultimate gift, if a person passes away with ataxia, a brain donation can give us more information about those internal pathways and how they were affected by the genetic or non-genetic factors. So, I think there's a lot we can do to build the foundation that the drug companies work from. But I believe that there are things that may be beyond our control. Certainly the National Ataxia Foundation does a fair amount of lobbying on Capitol Hill, working towards, any regulatory changes that could enhance, trials and drug development. But I think it's important for, all of us to stand up and be counted. Whenever I'm contacted by a drug company or an investment group that has some interest in something new to do with ataxia, I'll talk with you, I'll give you information, I'll, direct you if I can, just to let them know that this is such an area of importance for people with ataxia. But things that we learn and develop in the ataxia arena, I think could be applied to other more common disorders, so that all the work that's being done in Friedreich's ataxia, developing drugs to stimulate mitochondrial energy production, could be applied to much more common disorders where there's also an internal energy crisis. Parkinson's disease, Alzheimer's disease, ALS. So that we need to take advantage of the fact that we've got good research going on, which could have broader application, and publicize that as best we can and participate. I'm doing my best to participate in every drug trial that's being offered, which is why I end up spending so much time in clinic, and unfortunately miss some of the meetings the National Ataxia Foundation puts together, but I'm glad to be able to spend this time with you this morning. So yes, Lori,
Well,
I could
well,
go on
thanks
and
so
on
much,
about this.
Dr. Perlman, for really highlighting all the ways that the community can really get involved and help with this effort. We have another question from Amy. Amy has EA2, and she recently suffered a concussion. We wish you well, Amy, out there. She's wondering if this will permanently affect her ataxia negatively, or does it vary by person?
It varies by person, and this is on the foundation of concussion, whether it's in somebody who has no predisposing, brain issues like episodic ataxia type 2, whether it's in somebody who has, had an underlying, genetic problem affecting the cerebellum, for instance, or, affecting the brain, so that, it's known that concussions acutely in the first few weeks after a person has a concussion, there are going to be symptoms that, brand new symptoms. There might be headache, there might be a neck pain, there might be visual blurring, dizziness, different from the dizziness you might be experiencing with EA2, for instance. Most of these post-concussion symptoms will go away. Sometimes it can take 3 months, sometimes it can take 6 months. And I remember from the early times in my training, we once had a journal club, with our then chairman, talking about post-concussion syndrome that could last for a year or more. So I think it's important to avoid head injury if at all possible, but to recognize that, the symptoms of concussion can overlap and, add to your already recurrent ataxic symptoms. If the concussion is severe enough, you could have damage. You could have a closed head injury or a traumatic brain injury that will add new damage and could worsen your brain's adjustment to the underlying genetic problem, as well as adding new issues. So for instance, I have a patient with a genetic metabolic disorder, lifelong, doing reasonably well, slow progression over a period of time, fell backwards in her wheelchair, hit her head, and developed a severe concussion and a very focal traumatic brain injury that affected speech. So slowly over the course of a year, the headache, et cetera, went away. The speech problem gradually improved. And she was back to a reasonable baseline. However, she got sick with a severe febrile illness, not COVID, but something else. And many of her symptoms came back, suggesting that her underlying reserve had been worsened by that head injury. So I think it's the severity of the head injury. I think it's having patience to see of natural recovery that will determine how a concussion could influence you. But it won't make the underlying genetic problem worse. It will just affect the same pathways.
We have another question here from Jan in Florida. She is wondering if you have ever treated AVED and how.
I have never treated it. And if I were presented with an individual with, this vitamin E deficiency, I would immediately go back to the literature and look up current treatment protocols. And there are some, very good resources for this, for genetic disorders like AVED, the neuromuscular homepage out of, let's see, I'm trying to bring it up here. WashU in St. Louis has a nice summary of all of the cerebellar disorders, including AVED. And I can go through that. Let's see if I can find it. All right, it's alphabetical, so it should be near the top. And, like I say, I don't know everything, but I like to think I can find pretty much everything I need to know. So I'm not going to bother you with my scrolling here, but I know that AVED, other rare inborn errors of metabolism, A beta lipoproteinemia is another one that affects vitamin E metabolism and use. There are protocols for treatment of these conditions, which your neurologist, the pediatric neurologist, should be able to find out. So ataxia with selective vitamin E deficiency is missing a transfer protein that moves vitamin E into the places where it needs to go. And let's see. Shares some similarities with A beta lipoproteinemia, since the beta lipoproteins also move vitamin E through our system. And treatment is with vitamin E supplements, 800 milligrams per day, and a high-fat diet to improve their absorption. So, you know, this is what goes on in clinic visits. I have somebody sitting here who's asking me the same question, and we go online together and we try to look up things that I may not have at my fingertips. But certainly, you know, any physician who takes the time to work with you can find out what research has been done and what the current recommendations are.
Well, thanks for supplying that resource, Dr. Perlman. We have a couple of dozen questions now in the chat. So how are you looking for time today?
Is that a question?
Yeah, it is.
So how am I looking for time? You know, could we go longer than an hour?
Right.
Okay, we could go longer than an hour. I have a clinic that starts at 1 o'clock my time.
Okay.
And I know that, you know, we're scheduled to stop at noon, but I could certainly go a little longer.
All right, that would be great. Well, we'll do as many as we can, and let it get to the next question here from Michelle. Is there any treatment for neuropathy?
Is there a treatment for the cause of a neuropathy? Is there a treatment for the symptoms of neuropathy? Is there a treatment that will help heal neuropathy? So certainly if we know the cause of a neuropathy, if it's a vitamin deficiency or too much of a certain vitamin, vitamin B6 taken in too high of a dose can cause neuropathy, just like a deficiency of vitamins can lead to neuropathy. Diabetes can lead to neuropathy. So these are metabolic causes of numbness, tingling, or nerve pain that are very treatable, you know, by the cause. You know, you replace the vitamin, you reduce the vitamin, you make sure your diabetes is under control. Many genetic disorders will have an associated neuropathy. Friedreich's ataxia is one, Machado-Joseph SCA3 is another. So there, unless you find a way to cure the causative ataxia or restore energy to the system or, you know, get rid of the abnormal protein, the odds are good the neuropathy will be there and you're going to be focused on treating the symptoms. The symptoms of neuropathy, there can be motor symptoms, weakness, muscle thinning, and atrophy, which is usually treated by physical therapy. There can be sensory symptoms, numbness and tingling, which is usually not treatable, although pain associated with the numbness and tingling is very treatable. You know, one of the most commonly used medications now is gabapentin, which seems to calm down the irritability of those peripheral neuropathy nerves and reduce the pain. And then there are other medications, you know, related to that that can be used for neuropathic pain. duloxetine, Cymbalta, Lyrica, which is the next generation gabapentin. So certainly the symptoms of neuropathy, with the possible exception of numbness, can all be treated. Cause of neuropathy can be treated if you find the cause. So this is something that I think your physicians should be focused on. Just because you have Machado-Joseph's disease doesn't make you immune from other causes of neuropathy. You could have diabetes that's contributing to it. You could have a B12 deficiency, which is very common as we get older, that could be contributing to it. So these are all reversible causes.
All right, so our next question, this is a really good question. This attendee is new to this and is wondering, what is the most affordable way to get genetic testing?
Okay, the most affordable way to get genetic testing. And is this an individual who has a genetic condition in the family, or is this somebody where it's unknown by the family history, but age, a younger person more likely to have a genetic cause? So often when a physician is working with a patient to set out a treatment plan and order blood work, for genetic testing, they'll look for a family history, which will reinforce their interest in pursuing genetic testing for dominant diseases, genetic testing for recessive diseases. They'll look at the presentation, a younger person, slowly progressive problems, you'd think could be genetic, worth looking at. Older person over the age of 70 with, kind of a slowly progressive ataxic syndrome. You might not think genetics right off the bat, but, I have a patient with Friedreich's ataxia who didn't develop any symptoms till he was 69. So in our clinic, people referred to us, people that we are seeing who are self-referred, genetic testing is always on the list. Okay, so that's number one. You have to think of doing it. Number two, how do you get it paid for? Well, number two is there a lab that will do testing? Now, the NIH has a website that grew out of a website called Gene Tests, and it's now been, formalized at a higher level. And you can type in, we will attempt to do this again. You will type in Gene Tests, and the website will come up, the Genetic Testing Registry, or GTR, at the NCBI, which is the national level, part of the NIH, and you can look up labs that will do testing for, let's say, AVED, since we were talking about that. So you have a patient, you think it's AVED, you would like to do a test for that genetic factor that results in loss of the transfer factor, and you can click on, the disease comes up, you click on tests, and you can find, let's say, diagnostic tests that are in a certified laboratory, and let's say they're in the United States. So with those three criteria, I get 41 labs that will include testing either as a panel or as a single gene test. So number one, we have the suspicion. Number two, we know there's a lab that will do it. So the next thing is number three, who's going to pay for this? So if you have some concern about getting genetic testing on your record, which fortunately is less of a concern now with the GINA legislation, which protects people with genetic disorders from being discriminated against in health insurance, not in life insurance, not in long-term care insurance, not in disability insurance, but at least with health insurance. You can pursue genetic testing, you can get a genetic disease in your health record, and you won't lose your health insurance. So, we will look at, the desire to be tested. You could go through somebody and say, this could be genetic. Here's a lab we could send some blood to. Do you wish to be tested? And many times an explanation is required. Will it be helpful? Why should I do this? If it's positive, what do I tell my family? There are so many things that can be involved in that decision. And so the final step, once somebody says, yes, I want to be tested, is how do I pay for it? Will my insurance cover it? Back in the dark ages, insurance, flatly refused to cover 99% of genetic testing because is it going to make a difference in what you do, doctor? There's no treatments for this. Why should we pay for something that's not going to change your treatment plan? They didn't want to hear that it's important to know what you have. It's important for the family to know there's a genetic factor involved. This was not part of, are you going to treat this disease that you found with genetic testing? If not, we're not going to pay for it. Many of them have loosened up now. Especially as I think the cost of genetic testing has come down if you choose it selectively. There are still panels which will test for 25 different genetic disorders that are related to each other that can cost $18,000, and your insurance company probably will not pay for that. There are companies that have come up through the ranks now and are doing the same genetic testing, and to be competitive, the cost is lower so that you can get screening for, let's say, the dominantly inherited genetic ataxias that run in families, a panel of the common ones, you can get for $1,100, $1,000. Not cheap, but if it's something that's going to be important for you and your family, it's something that could be budgeted in. Or if it's cheap enough, your insurance company might pay for it. Single gene testing usually is around $300 to $400, depending on the gene, depending on the company. So that if you have an insurance company that will not pay for genetic testing, there are opportunities to self-pay that you won't have to necessarily mortgage the house for. If you're going to your insurance company and they're willing to pay, you might have to, instead of testing for all 25 genes that could look like what you have, you may have to work with your doctor to be a little more selective in what you choose to be tested for. And that choice can, vary, around, a trial that you want to enter. And it would be important to know if you have that genetic disorder or not. So there's some debate in there. There is a move on the part of the National Ataxia Foundation to make genetic testing for certain genetic disorders without charge for people whose insurance won't pay, people who don't have insurance, even people where the copay, their responsibility would be excessive. And I know that the NAF is working on developing this program. And I know that there are various programs around the country that will do some of the more expensive genetic testing, like the medical version of 23andMe, whole exome sequencing, can run upwards of $8,000 or more. Many insurance companies won't pay for it because they think it's a fishing expedition. But there are academic institutions like mine and others that, as part of an internal research program, will do free exome sequence testing that they will be able to share some information for the people who participate in those programs. And there's, a fine line between having testing done in a registered approved lab or in an academic research lab, and will they give you the results of your testing? And, it's, sometimes yes, sometimes, a little, backing off and saying, we can't give you the results right now. But I think now that there are clinical trials in process or being developed for genetic disorders, that assuring access to genetic testing is one of the main missions of the National Ataxia Foundation.
That's absolutely right. Would you say that a genetic counselor can help people navigate some of those questions as well?
Genetic counselors are far more fluent in what's available, what testing to choose, where to get the testing done, how to sequence testing. If you send your first choice and it's negative, can you go back to the same sample and do another test on it? And this is the expertise of genetic counselors who do spend time with us in our ataxia clinics as part of their training. So I think going through a genetic counselor could be a good way to help isolate the best path to navigate to get the most appropriate genetic testing for you. I just saw something pop up there where somebody, mentioned that there was a company or a service offering whole exome testing for $600. I know that there are companies that are offering whole exome sequencing at reduced prices, but you want to make sure that they're doing, focused versus non-focused testing. Whole exome sequencing, can look at hundreds of genes, or it could be targeted just to genes that we know are involved in ataxia pathways. So, and obviously the cost would come down. So you need to find out if that company is a reputable company. Are they licensed? And, what depth and interpretation do they put into their whole exome processing?
Sure. We have some interest here in CRISPR technology. One question is, what's a realistic time frame for the CRISPR technology to become a viable option for treatment?
I often tend to condense timelines. I have patients who remind me, Dr. Perlman, 15 years ago when my gene was discovered, you assured me there would be a treatment in 5 years, and it's now 15 years down the line, and there's still no treatment. So, I sometimes tend to be optimistic that once we know the gene and how the gene behaves and what set dominoes it triggers, that treatments can be developed. And certainly CRISPR is one of those treatments. So, and I know that there's been a lot of work done in petri dishes, in test tubes, in animals. I believe there has been some CRISPR work done in humans, which I am not familiar with. The diseases and the outcomes there. But I think a reasonable timeline for use of CRISPR to snip out a CAG expansion in Machado-Joseph's disease. Probably if we're looking at gene blocking therapies within the next 5 years, I think we're looking at CRISPR, gene repair therapies, probably within 10 years. And that's only if they can be targeted in the complex human body to get where they need to go, safely, without any unintended side effects. Whenever you're manipulating genes, there's always a risk that, something else is going to be altered by, what you're doing, not just target. So you do have to be careful. This is just a fancy way of saying I haven't looked at the CRISPR literature recently, but I'm certainly going to go back and do that. So that the next patient who asks me about CRISPR in clinic, I'll have a little more coherent response.
Well, that is exciting. Thank you for that. We have a question about Nystagmus. Is there a surgical cure?
There is no surgical cure for nystagmus. Nystagmus comes from the inability of the cerebellum to coordinate eye movements, such that it's like a tremor. If you have a cerebellar tremor and you're going for a target, you'll notice that, as closer you get to the target, the shakier your hand gets. It's the same thing with nystagmus. When you're looking to one side, looking to the other side, looking up, looking down, to hold that target without tremor is often a problem in ataxia. So the treatment of nystagmus is usually with medication. It's not with surgery, and there aren't any glasses technologies that will help that.
We have a good question here. One of the attendees is asking for suggestions for treating depression, as many ataxia patients also have depression. Is there any new therapy besides the traditional talk therapy and antidepressant drugs?
Depression can be part of any chronic illness, can be part of any life that we're living. If we're, being limited by COVID and have spent 2 years in our home, not going out, that can be depressing. So certainly talk therapy, working, meeting, even virtually with other people who are grappling with the same challenges and stressors can help, with your mood, can help you understand, your depression better. Certainly antidepressant medications can work to boost brain serotonin levels, relieve some of the symptoms of depression, not just the sadness and the hopelessness, but also the decreased energy levels. So that, usually some combination of medication and talk therapy, or, some type of group therapy or support therapy works the best. Now, there is transcranial magnetic stimulation that has been approved for treatment of depression and is currently in research studies for treatment of ataxia. This was being done at Boston University, and I think it may be being looked at in other places as well. So transcranial magnetic stimulation, where you use magnets to stimulate electrical pathways in the brain that can modify mood related pathways, as opposed to electric shock therapy, which directly shock those pathways, I think is something that's available. The ataxia itself, as we know, can contribute to problems regulating mood pathways. It's the cerebellar cognitive affective syndrome, that the cerebellum coordinates not just movement and balance, but it coordinates mood, it coordinates speed of memory. So, we may find some changes in multitasking, some changes in regulating our mood. When we don't have any other reason to be feeling depressed, it could be coming from the ataxia itself. And again, the best way to manage that is with some kind of supportive therapy and use of medication. Some people, where there's a biochemical reason that their serotonin pathways are underactive, from all the complexity in our makeup, they need to be on antidepressant medications for a long time. Sometimes people only need that boost for 6 to 12 months, and then they've reestablished their approach to the world, they're working with a counselor or a support organization, and they can carry on without the medication. So I think you need to look at it from all aspects. But the transcranial magnetic stimulation is an interesting approach that is in practice right now. There are practitioners who are using it.
That is really interesting. Thank you for that information. Our next question is from Jan. Jan says that her dad was diagnosed in his late 70s with OPCA. And she's just really confused as to how we became ataxia and how she should discuss that with her doctor.
So
with their doctors.
Okay, so her father has OPCA, but she does not, apparently. And this was something that came on when he was over the age of 60, it appears. OPCA is old terminology that is really based on brain MRI. Olivopontocerebellar atrophy, OPCA, means that on a brain MRI scan, there is some shrinkage of the cerebellum, the pons, the olives, which are in the brainstem and send signals into the cerebellum. So that it's really an anatomic diagnosis based on an MRI. It is not a genetic diagnosis. It's not even a diagnosis that can point to a cause. There are many acquired and genetic factors that can lead to atrophy in those areas. So I think OPCA is a radiologic diagnosis, but the true diagnosis that will give us tools to intervene is much beyond what that is. So you would wonder in an older person, somebody with onset of ataxia, let's say after the age of 60 or 65, genetic factors a little less likely, but not zero. Acquired factors much more likely. Vitamin deficiencies, immune system problems, poisons, toxins. There's a variety of things. And there's also an incompletely understood accelerated aging of the cerebellum, which we now know as idiopathic late onset cerebellar ataxia or ILOCA, where for some reason the rest of the brain is aging at a normal rate, but the cerebellum is aging faster and causing balance problems. Screening for vitamin deficiencies, screening for other risk factors, screening for common genetic factors has been negative. Whole exome sequencing has been negative. There's a large group of people, probably 40% of people with late in life or later in life onset ataxia, where it's still, the triggers are just not known. They have something to do with aging pathways, something to do with pathways in the cerebellum. So in this particular case, if progression is rapid, it can lead to greater disability in a shorter period of time. If it's slowly progressive, it's often easier to manage with rehabilitation and symptomatic medication. So I hope that this individual's father has been thoroughly worked up for all the factors that could be treated, and is involved in rehabilitation and potentially symptomatic medication that could help reduce the symptoms.
Thank you for that advice, Dr. Perlman. We do have a COVID question. So this attendee is wondering, so she had the J&J shot for COVID, no booster yet though. She got COVID last month and is wondering, does she need to get the booster?
They say that if you have COVID, it kind of pumps up your immunity, and they don't recommend getting the vaccination or the booster for like 3 months, I think at 90 days. After that, any immunity from the infection, any immunity from the prior, initial vaccine may have declined. So if she wants to get the booster, and as far as I understand, it doesn't have to be the same vaccine. At least with Pfizer and Moderna, you could have gotten the initial Pfizer series and gotten a Moderna booster, or gotten the additional Moderna series and gotten a Pfizer booster. I don't know with J&J, but it needs to be discussed with your doctor. But if you've had the infection, you've got 90 days where you don't have to worry about getting a booster. Is I believe the recommendation that is still current. Oh, literally from day to day, you read the headlines and there's something new. So I think we all have to not panic about this, but recognize that appropriate precautions, following the science, and protecting yourselves and protecting your loved ones.
Absolutely. So Elizabeth's question is, as a treatment is found for one SCA type, would it translate to other types?
Yes, not all treatments, but many of them can be used for any cerebellar disorder, or could be used for similar cerebellar disorders, let's say the triplet repeat disorders, where the gene has a segment of the gene that is expanded, is too big. And you can develop a treatment that you can target to the SCA3 gene, the SCA2 gene, the SCA1 gene, with just a little tweaking so that you target it to the different genes, but the same mechanism, the same approach will be used. So, I think even with very rare diseases, in the ataxia lexicon, a treatment, even a gene replacement treatment, for a specific disease, that technology can be used for another similar disease. You're muted.
Thank you. Sorry about that. Our next question is from Deb. Deb has SCA6, but no symptoms. Is there anything that she can do to delay? She is 40 now.
The strategies to delay onset of any of the genetic ataxias debated. I think there is general agreement from animal work that putting the mouse in an exercise wheel and letting it do its cardio every day can delay onset of ataxia in that genetic model in that mouse. It's a big step to say that the same thing in an individual who carries a gene mutation that at some point is going to cause symptoms, that if you get on a good cardio program, you can increase your nerve growth factors and they'll be neuroprotective. There's been thoughts for decades now that antioxidant vitamins can help reduce free radicals, which are the end result of many of these genetic stressors. Free radicals are part of the mix of things that ultimately put stress on and causes nerves to die. I think attempts to show in individuals with various genes that high dose antioxidants can delay progression, they haven't been successful in delaying onset. So I think the things that are most protective are the general list of things that protect against brain aging. So there's been a lot of study done in aging. I think it's a huge area of study now for decades. And we know that brain aging mechanisms, and there are many of them, are probably part of the reason why somebody can have a gene from when they were born that doesn't cause any symptoms until they hit the age of 45 or 50. What has your brain been doing before then to protect you? And why all of a sudden is the brain not able to keep up? And I think one thing we know about the brain is from the age of 30 or 35, the brain is aging. We are losing nerve cells. We are losing reserve. So all the anti-aging research about the benefits of exercise, the benefits of various healthy diets, avoiding things that put stress on the brain, like excessive alcohol, recreational drug use, too much head trauma. If you're a football player in your spare time and you carry a gene for a genetic disorder like one of the ataxias, repeated concussions will probably move up age of onset in that, to a younger age. So, if I was to give any advice about, you're pre-symptomatic, you have a gene that runs in your family, it's, your body is compensating well for it, look at anti-aging literature and find out what the recommendations are for, a long life with a healthy brain and start integrating those now.
Thanks for that advice, Dr. Perlman. We're going to take a couple more questions here. We have a question that starts with a comment. Hi, Dr. Perlman. Many thanks for this call. Would you think we should start our 5-year-old FA son on the common supplements, idebadone, thiamine, or might he be too young? His symptoms are very subtle, currently less athletic than his peers, but genetic testing has confirmed FA.
The antioxidants that were the focus of early treatment trials in Friedreich's, not going down to age 5, but looking at teenagers and young adults and older adults with Friedreich's. Vitamin E and CoQ10 in the British study were felt to slow progression after they followed people for 5 or 6 years. Idebenone, was felt to have some antioxidant impact that could be important. There were studies that suggested it could protect the heart. And I don't know if your son has heart involvement, if it's been looked at or documented. Is idebenone enough to prevent progression, from this early age in the brain as opposed to in the heart? I don't think anybody has studied that. I know with some of the newer generation mitochondrially targeted agents, like the Edison company's EPI 743, which is now PTC 743, there was evidence in the young adult population that was studied under Edison that over a 2-year period, it could slow progression. So theoretically, it could slow progression in a young child as well, a child who has had the frataxin protein deficiency since they were born. And there are probably changes already present in the nervous system that are mild, and there's still reserve to make up for them. But at some point, progression will allow more visible ataxia to appear. Could it be slowed up by vitamin E, CoQ10, idebenone? Thiamine is another one that's been looked at, as well as some of these newer agents. When some of these newer agents get approved, will they be tested for dosing and safety in this pediatric population and started at a younger age? I would vote for that. I think using something that the child is willing to take, idebenone, hard to get. Now that it's fallen into that gray zone between a nutritional supplement and a drug, when it failed its FDA trials, it kind of ended up in this wasteland in the middle here. But I think if I were to recommend something, I would recommend vitamin E, maybe 200 international units, something to start with. It does access a part of the mitochondrion that is important. The Edison drug, PTC drug, accesses the vitamin E pathway in a stronger way. So I think if I were to recommend something, I would go with a small dose of vitamin E, and wait for some of these drugs in the pipeline, which within the next 2 to 3 years, some of the mitochondrial drugs will have finished their safety testing in the pediatric population and will be available for use in an early or minimally symptomatic youngster.
Very good. Thank you for that suggestion, Dr. Perlman. We have a couple people that seem to be experiencing a similar symptom with night sweats. Are night sweats common or unrelated to ataxia?
Night sweats. When we think of night sweats, we think about underlying infection. We think about hormone changes as we get older. We think about autonomic changes in ataxic disorders, which affect autonomic nerves. So we're talking about ataxic disorders that cause peripheral neuropathy. There are some that can affect the autonomic nervous system, which controls sweating, it controls pulse, it controls blood pressure. So if you're having night sweats, diabetes can cause night sweats. So there's a lot of common things that can contribute to that. Aging, hormone-related factors, diabetes not well controlled. Certain medications can cause sweating at night. And certain ataxias can contribute to that as well. So I think it's important to make sure that there's nothing, very specifically treatable that's behind the sweating problem. And if it is an autonomic dysfunction, there are medications that can quiet that down. And I think that's a discussion to have with your primary care doctor.
That sounds good. This person also experiencing the night sweats also has spells where they're freezing and then boiling back and forth.
The cold, hot, red, purple foot problem that many people with Friedreich's get is a result of the peripheral neuropathy affecting peripheral circulation. If it's a more generalized temperature dysregulation, I would again look at the autonomic nervous system. In multiple system atrophy, the autonomic nervous system is involved. It can be involved in some of the genetic ataxias as well, especially spinocerebellar ataxia type 3, Machado-Joseph's disease. And, I won't say that there are good medication ways to regulate it, but it's worth a discussion with your doctor. And if you find an herbal supplement that touts its ability to deal with hot flashes, and you want to try it for 2 or 3 months, as long as you clear it with your doctor, it doesn't interact with any of your other medications, don't be afraid to bring up the results of your research, in the literature, in natural healing, and discuss it with your doctor to see if it would be helpful. But when I hear about temperature dysregulation, it's an autonomic phenomenon. Comes from the brainstem, comes from the autonomic pathways.
Gotcha. Do you have any advice on how to combat fatigue?
Okay. Ataxia causes fatigue. Ataxia with sleep disorder, and many people with ataxia have disturbed sleep because of restless legs, because of muscle spasms, because of sleep apnea, because of vivid dreams or nightmares. There are many things that can disrupt sleep in the ataxia population, which can add to daytime fatigue. If you have peripheral nerve involvement, certainly peripheral nerve involvement that can alter muscle-related communication, you may have muscle fatigability. So it's important to decide, is it a more generalized fatigue? Is it an excessive daytime sleepiness? Or is it actual muscle fatigability? Where is it coming from? If it's neuromuscular fatigue or fatigue from deconditioning because your ataxia is so severe, you really can't safely exercise, you get deconditioned, muscles become innocent bystanders. Some type of gentle home exercise program to get those muscles moving will improve muscle strength and muscle endurance and reduce fatigability. A good daytime exercise program can help you sleep better at night. If your nighttime sleep is disturbed by some of these other factors that I mentioned, sleep apnea, vivid dreams, periodic leg movements of sleep, there are treatments for that. So I think you have to figure out, is there some reversible factor behind my fatigue? If it's really just from the ataxia, there are anti-fatigue medications. Antidepressants that have a little adrenaline activity as part of their chemistry can be very helpful for fatigue, especially if you're depressed and fatigued. There are drugs used for sleep disorders and excessive daytime sleepiness that can also be tried for general fatigue, even if your nighttime sleep is reasonable, except then your insurance company might not pay for them because they're approved for fatigue due to nighttime sleep disorder. But there's often ways to get around that. And Good RX, has coupons that can get you these things cheaply. And these are things like Provigil, modafinil, Nuvigil, armodafinil, are the ones that were originally developed to deal with excessive daytime sleepiness as a result of a sleep disorder, but may be helpful for fatigue, even if your nighttime sleep is restful. So I think it's something to look at from, appropriate exercise, appropriate sleep hygiene, and then anti-fatigue medications. I wouldn't advise using, speed, street drugs, not advisable. Some of the drugs used for attention deficit disorder, will stimulate those pathways. Ritalin and there are others, but I have used those in some patients with ataxia and fatigue, and I think Provigil, modafinil, and that family work as well, and are less likely to cause problems with addiction, etc. So it's eat healthy, sleep healthy, exercise right, and then look at additional things you can do in the way of medication.
That's great advice. There's a question here from Jeff. Jeff's question is there a difference between EA2 and SCA2? And if so, can you explain the difference? He is diagnosed with EA2.
So the difference between EA2 and SCA2, okay. So I noticed there was a little question before about whether, the spinocerebellar ataxia nomenclature can be used for any form of ataxia. Well, technically, we're using spinocerebellar ataxia type 1, 2, 3, I think they're up to 48 now, for identified genes causing dominantly inherited ataxia. So spinocerebellar ataxia type 2 was the second of these genes to be discovered. It was discovered in 3 labs simultaneously, one in, I think, Japan, one in France, and one here in the United States. It's a triplet repeat disorder that causes buildup of, an abnormal protein that is too big. The gene is too big, it makes a protein that's too big. The protein gets broken up because it's an abnormal protein. The little fragments stick together, make aggregates inside the nerves, and ultimately kill the nerves. So it's a gain of function disorder causing ataxia and other symptoms along the way. Age of onset, usually in somebody's 30s, sometimes younger, sometimes older. Episodic ataxia type 2 is in the group of episodic ataxias, and I think they're up to 8 now, episodic ataxia type 8. Episodic ataxia type 2 was one of the first ones that was discovered. It is caused by a point mutation in that gene that makes an important protein that is involved in the structure of the nerve membrane. So it's like putting a weak brick into the wall. And specifically this wall is the calcium channel, which controls the flow of calcium in and out of nerves in the cerebellum, in the Purkinje cells. And this weak brick that has this small mutation in it, in episodic ataxia type 2, causes that calcium channel to malfunction, so that sometimes it closes before it's supposed to. Sometimes it stays open too long, altering the ability of the Purkinje cells in the cerebellum to function properly. So you get episodes of ataxia. In between episodes, you may be perfectly normal or very close to normal. It can have, changes that may affect vision. It can cause nystagmus. It can cause dizziness. But the key thing is that it's episodic, and it's a different gene mutation in a different gene that behaves differently from SCA2. Now, the interesting thing about episodic ataxia type 2 is that it's a mutation in the same gene that causes spinocerebellar ataxia type 6. But in spinocerebellar ataxia type 6, it's an expansion abnormal protein. In episodic ataxia type 2, same gene, it's a small mutation that alters the function of the protein that is produced. Both of them can, start out similarly, mild balance problems, some dizziness, it comes and goes. Episodic ataxia usually starts earlier in life. It clearly has episodes. Spinocerebellar ataxia type 6 starts later in life. It may begin with episodes, but ultimately leads to progressive ataxia, while episodic ataxia type 2, at some point after years of episodes, there might be some residual ataxia there. But, in general, they look very different. and the treatments are going to be different. So that with the spinocerebellar ataxia type 2, CRISPR, let's snip that mutation out of there. Let's find a way to block production of the abnormal protein. Episodic ataxia type 2 might respond to gene replacement. Just get a normal copy of the gene in there. You already have one that's making normal bricks, as it were, and you got the mutant one that's making abnormal bricks. So maybe you could load up more copies of the normal gene, make more normal bricks, and overpower the weak brick side. And I'm sure there are other approaches as well, things to stabilize the channel. So that, there are treatments that are known to be helpful for EA2, just like there are treatments in development to help the other spinocerebellar ataxias.
That's great. Thank you for that, Dr. Perlman. We're just going to do one more question. And this is a good question. Is there a way to access treatment from other parts of the US, or care, I would say, from other parts of the US rather than UCLA?
Well, NAF has a list of ataxia clinics and ataxia specialists around the country. We all know each other. We get together on a regular basis. We share information. We participate in the same trials. So I think we should look to NAF to give us, our regional experts, and how we can access them. Even in areas where there may not be an ataxia expert, I think one of the few benefits to come out of COVID, besides the decreased traffic in Los Angeles, is that telemedicine is now accepted to be done across state lines. Previously, you could do telemedicine, but only within your state. Now it's accepted to be done across state lines. So if you live in Hawaii and there's no ataxia expert there, but you want a telemedicine consult, some advice, and some follow-up with an ataxia expert anywhere in the United States, the continental United States, you can do that by telemedicine now. And there's movement now to make clinical trial participation at least partly available by telemedicine approaches. That, for a drug trial, you figure you have to show up in person and undergo a lot of examinations in person, but there are efforts on the part of industry to make it easier to access, remotely, at least for some of the visits. And this has been given a huge boot by, the whole COVID world as we're living in it now.
Absolutely. I would encourage anyone that wants information on the ataxia neurologist that we have listed on our website to contact us or visit our website. You can email us at naf@ataxia.org. And also, Dr. Perlman had mentioned the natural history studies earlier on in this session, and you can certainly contact us for information. And it's also on our website as well. I want to thank you again, Dr. Perlman, for all of your time and for joining us for just a bit longer today. We truly appreciate all of the information that you shared with us. And it's so great to see you.
And it's great to see. It's great to see a lot of people I recognize here from their little photos and videos and stuff. And I'm absolutely looking forward to when we can begin to have in-person, ataxia meetings again like we used to, just so we can spend more time together and really talk about things in detail. So thank you again.
Well, I am certainly looking forward to that, as well as so many in the community. And today we had over 360 attendees. So thank you all out there who took the time to join us today. Dr. Perlman had mentioned meeting together. We hope that you all have information on our upcoming Ataxia conference and are able to register for that event. It is virtual, but we'll be there together, getting some great information and sessions and networking opportunities there. So information on our next conference is available on our website. If you did want to go back and reference anything in today's session, a recording will become available on our YouTube channel. So Look for that there in the upcoming days, and then also in our e-newsletter. So until next time, take care, everyone. Bye.